Welcome to Unmute Your Probe, a podcast from the AAEM ultrasound section. This podcast explores current controversies, research, and best practices in point-of-care ultrasound. CME is available for AAEM emergency ultrasound section members through the AAEM website. I'm your host for this episode, Dr. Melissa Myers. I am an associate professor of military and emergency medicine, and I do hold a designation of focused practice in advanced emergency medicine ultrasonography. But today, the focus is on our fantastic guests, Dr. Ashley Grant, Dr. Zach Boivin, and Dr. Andrew Shannon, who will be discussing ultrasound-guided nerve blocks, their benefits, pitfalls, and practical application in the emergency department. Why don't you guys start by introducing yourself? Dr. Shannon, let's start with you.
Sure. My name's Andrew Shannon. I am actually currently one of the EUS's counselors with AAEM, so for the section interest group. But my work is I work in the emergency department. I'm the ultrasound director for the residency that we have, and I help out with point of care teaching throughout the hospital. So I'm in Lakeland Regional Medical Center, which is in Central Florida.
Awesome. Dr. Grant?
Hi, everybody. I'm Ashley Grant. I am the ultrasound director for our residency program here in Sarasota, Florida at Florida State University. I also hold a focused practice designation for a EMUS and happy to be here today and talk about regional anesthesia.
All right, Dr. Boivin. Am I saying your last name correctly, by the way, before I do it wrong for the entire episode?
You are. So my name is Zach Boivin, and I am ultrasound faculty member at Yale, completed my fellowship last year. I am the director of resident ultrasound education for the residency at Yale.
Thank you for coming back on the show. So today we're talking about emergency physicians performing regional anesthesia. And I think we should start with the basic question. Is this something we should be doing? Certainly there are folks out there that think this is not in our scope. It's too dangerous, too many pitfalls, and not necessary. So what would you guys say to those folks?
I'm happy to jump in there first, but I think my answer is yes, perhaps predictably. I think that this is something that's well within the scope of emergency medicine practice. We deal with putting needles in places where you may not want a needle unless you absolutely need it all the time. We have been the leaders of ultrasound point of care generally, and then moving ultrasound guided procedures from the interventional radiology suite or that kind of area to the ED at the point of care where patients need them most, in particular when it comes to analgesia. This is something we can do, and there's been a raft of research about the fact that we can do it competent. And then we have the research as well that it saves us some time and patients like it, but also that's just from personal experience. If you can get someone feeling better more quickly, then why the heck aren't you doing that? I'm obviously on board.
I agree with Andrew here. I think as emergency medicine physicians, we always need to be versatile in the treatment options that we offer to our patients. And specifically here in Sarasota, we have a rather large elderly patient population that sometimes it's not a great idea to just give grandma boatloads of fentanyl and Dilaudid for her hip fracture. Oftentimes, regional anesthesia is actually the safest option for us. So I think it's important to have multiple tools at your availability.
I agree. And going along with what Ashley said, Yale's emergency medicine is primarily focused on decreasing opiate use. And I think that this offers a great solution to do that, not just in the elderly population, but patients that you can just do a nerve block on and may not have to send them home with opiates for things like a rib fracture, for example.
I'll circle back to something you guys just made me think of. Also, just from a shift management point of view, if you can do an ultrasound guided block yourself, then you get basically the same effects. And perhaps we'll talk about this as like a procedural sedation or analgesia. You're not tying up a nurse as much. You're in control of when you can actually start that block, let it marinate, then come back to do the procedure if you have to do something else. So there's a certain amount of control when you're thinking about all these different techniques, and ultrasound-guided regional anesthesia is just another tool in the toolkit.
Absolutely. If I was working in a single coverage place or a low resource place, this is definitely something that I would want to be a master of. Shoulder reductions, the amount of times where I've been able to do like an interscaling block and be able to reduce the shoulder. Sometimes the patient even reduces themselves, and I haven't needed to use ketamine or take up a patient or take up a nurse or then have the patient wait for 20 minutes for the ketamine to wear off. It really can help that flow and that resource utilization.
I can definitely personally attest to that one. I worked for years at a critical access hospital in rural Texas. And the hip fractures was my biggest use for this, because I didn't have to keep going back into the room to do that dance that Ashley, you were talking about. Am I giving enough pain medication to give pain control, but also not so much that this person stops breathing? Good hip block, and they're comfortable for 8 hours.
Hip fractures just in general, I think are hard to treat also with just your typical opiates, because oftentimes what the patient is having is like this intermittent spasming type pain. It's like a 10 out of 10 for a couple minutes. And then you try to chase it with an opiate and then they're snowed. Whereas you can do a block where they just have a more continuous relief.
So probably not shockingly, everyone appears to be in favor of nerve blocks. That said, I think we all know that as with anything, there's some downsides. So I would like to hear from you guys. What do you see as some potential downsides in doing regional anesthesia in the ED?
Last.
Yeah. So there's the big ones, like the general complications and problems with regional anesthesia generally. I don't know if we want to hit those last or if we want to talk about our the session brought to you by the makers of lidocaine. Yeah, exactly. The personal things, like, and I'll start with the therapy session, is like sometimes I don't get a great result. Right? So you look at some of the literature and it's not uncommon for around 10% or so of people to not get great analgesia, even in people who are doing, this is like regional anesthesia literature, right? So do I feel bad if I don't get a good result? Do I have to go in there and explain? I actually do it ahead of time, obviously, but just come in and say, yeah, sometimes we don't get a great result and everyone's upset and disappointed and you have to fall back on your other modalities. But the big emotional pitfall for me is when it doesn't work, which is unusual, but it's a known issue. And that's one of the things that you need to be clear about, the expectations for the patient, your consultants, and yourself when you're doing these blocks. Sometimes you get it even right off the bat. And sometimes you don't get it, even if you're using all the right techniques and using ultrasound to bump your numbers up for success.
Yeah, it definitely does happen. And it's incredibly frustrating when it does.
It was bound to happen.
Yeah, of course. So for me, the biggest, it's not necessarily a pitfall, it's more of just a pain point with this, is hallway beds. So my goal is to do all nerve blocks in a room and to have the patient on a monitored bed. And I think that sometimes with the amount of boarding that we have in our emergency departments, with the need to see as many patients as come into the emergency department, that can be difficult at times. And if I'm doing a fascia iliaca block, I'm not doing that in the middle of a hallway bed. So then I either have to switch a patient out of a bed or I have to take a bed that is maybe for another patient or being saved for a critically ill patient. And so I think that can be a pain point at times for me. But I agree with Andrew. The biggest disappointment is when you go through all this effort and it doesn't work.
Yeah, and I was just going to say that I'm not about to come on here and try to trick people into thinking that this is an easy procedure to do. I do think that these are procedures that if you're not doing them relatively regularly, you might not be as facile at it. You might not be as fast at it. And so it might be easier for you to just order that opiate for that patient with the hip fracture, for example. And you might not want to take the time away from patient care to do that procedure when you're not doing them often and you don't feel very fast at it.
And I think that's something that's the problem, if you will, of point of care ultrasound generally. And for those of us who teach residents in point of care ultrasound, or for those of you out there who are going to try to teach yourself some of this stuff, which is actually how I first started to learn nerve blocks. My fellowship was way back when it was like, hey, you can do the nerve block with ultrasound. So all my other stuff has been self-taught. But the idea of that learning, that time for that learning curve, you are more inefficient. That time that it takes you to get good at something. And there's that idea of I can just order the DVT ultrasound. And so the value of it really comes in is once you get good, you can see that efficiency uptick. And then, as I think Melissa pointed out, you don't know what your practice environment is going to be. And you better not lifelike someone out of the Aleutian Islands somewhere because you don't know how to do fill in the blank procedure. So there's always that motivation to get good at these procedures, but it takes some doing. Sure.
It does. Andrew, I had that same conversation year after year with the intern. I know it takes you 10 minutes to do this now. It will take you 1 minute in 2 years. It will take you 10 minutes in 2 years if you never do this. And then you're going to be in real trouble when you need it. It actually brings up something interesting because, Andrew, you sent me this paper, Bringing Ultrasound-Guided Regional Anesthesia to Emergency Medicine by Herring. And it talked about what I think you're getting at, this idea that to learn how to do this, you have to be in an environment where you have the ability to learn how to do this. And I was really lucky to be for years at an academic site with a strong cadaver lab. And we were able to practice our regional anesthesia blocks on cadavers prior to practicing on patients. I was extremely lucky to have that opportunity. So what would you guys say to someone who is maybe preliminarily interested in this idea, but reasonably doesn't want to maybe try it out for the first time on their patients?
First off, good for you. Because again,
Yeah.
you can finish your training and then practice it away for 30 years and be a perfectly successful physician, no matter your field. But constantly learning how to do things is the hallmark of emergency medicine. That's why we went into this. So great. There's a bunch of resources. I don't know if we'll get into that toward the end, but from the idea of how to start, one of the ways I would argue is low hanging fruit. And so some of my favorite blocks to teach initially are the things where it's a little bit more straightforward. We're used to needles and we're used to ultrasounds. So the thinking about that, whenever I'm doing a central line, for example, I always point out to my learners where the nerve anatomy is, start getting used to being able to identify some of those things. When you start to get comfortable when you're doing your sort of pre-scan, this is why the superficial cervical plexus block is one of my favorite blocks. Not only does it get some anesthesia for your IJs.
Love the superficial cervical block system.
Think about every time you do a central line, it's an opportunity to practice a block that is as far as procedures go, very low risk, very high reward. You've got lidocaine in your hand anyway. You've got the patient prepped anyway, and you're going to stick a bigger needle in there. So wouldn't it be great if that area were already numb? And so the ability to identify some of those nerves and get that in or out of plane or however you want to do it down is great. And that's the other reason, the other block I would do for that reason is I like starting with the median nerve block because again, there's very little around there that you're going to get in too much trouble with. It's a very common procedure and the metacarpal phalangeal head block is great, but sometimes that can also be uncomfortable. And I think the median nerve block in the mid forearm is the anatomy is easy to see and the procedure isn't so difficult. So those are the sort of beginner blocks I think about or that I would think about recommending.
I agree so much with what you said, Andrew. Like, I think that the median nerve block is a great starter block because it's such a safe block to do. But looking for those opportunities to perform those blocks, like maybe you wouldn't typically think of a nerve block for a hand laceration, but here's an opportunity to practice a low risk block that you can see the effect from and then utilize. So I think definitely starting with things like the median nerve. I also love like what you said about pointing out the anatomy when you're doing other procedures. So when you're doing a DBT study, pay attention to there's the femoral nerve and there's the fascia iliaca, like always trying to look for those opportunities to identify that neuroanatomy, even if that's not what you're necessarily doing the procedure for at that time. The other thing I would say for anybody on here who is looking into getting into doing nerve blocks and stuff like that is maybe if you're already doing ultrasound-guided IVs, start practicing doing in-plane techniques. I think, because I think that's a very important technique to be able to master when you're doing an ultrasound-guided nerve block. And once you're good at finding your needle and keeping your needle in plane, you can pretty much do any nerve block as long as you know how to recognize the neuroanatomy. So that's the hand skill that you need to master. And so start doing that with your ultrasound IVs.
So I'd like to move into talking about some specific blocks that you guys really enjoy doing and some of the blocks that you don't enjoy doing as much. Ashley, you mentioned that you really like the fascia iliaca and the ping block, and I have to be honest, I have a personal soft spot for the ping block. I think it's one of the easier blocks to do, and like I've mentioned, I think that hip fractures are such a great indication. So why don't you tell me a little bit about that?
Yeah, so we started doing fascia iliaca block years ago. Actually, ortho nursing and anesthesia came to our department to ask us to start doing these on the hip block. So it was a great opportunity. It was to get that ball rolling. And so we started with the fascia iliaca block, and then the pang block came into favor. And I find that the pang block tends to give better results. I do find though that my beginners are a little nervous with the pang block because they get better visualization with the fascia iliaca block traditionally, even though I think that the pang block is likely safer than the fascia iliaca block, even though your
Oh, I do too.
visualization is not as good. It's interesting. But once they do a couple of the pang blocks, I think then they start to really see the benefit of them. But you can use a little anesthetic when you're using the pang block. The patient's body habitus isn't as much of an issue with the pang block. You get less motor blockade. I think there's a lot of reasons why people should start looking to doing the pang block if they're not already.
It is really interesting to me that your beginners prefer the fascia iliaca because I've had the opposite experience. That my beginners were more comfortable with the pain because they had that thought of if I miss, I'll hit the bone. There's nothing huge around here that I'm gonna injure. And the fascia iliaca made them nervous. They're like, that is an artery. I don't like this.
Yeah.
All right. Speaking of, you'd have to be pretty far off base to hit an artery during the fascia iliaca, but I'm sure if you tried hard enough, you could succeed at it.
True. I often am like, I don't even want to see the artery in view. Let's be over there at the top of the hill. But it's with the pain block. I'm like, just please don't do a medial approach. That's all I'm asking. I'm lateral.
Go through the abdomen.
But yeah, it's safer for sure.
Yeah.
Yeah.
Now, speaking of arteries, you mentioned that your least favorite block is the axillary block. And I have to preface this by saying I was introduced to this by an old school anesthesiologist who told me that this is prior to ultrasound, that he would do his axillary blocks by inserting the needle until he hit the artery. And then he would backwall the artery and he would inject and then he would come out and then he would inject on the other side. And I was like, that sounds terrifying. Fortunately, now we do have ultrasound, but it sounds like it's still not your favorite block, Ashley. So why don't you walk us through why?
Yeah. I had also heard that back in the day, they did these blind with the same technique, which I will say at least makes me feel better about accidentally hitting an artery, considering they used to purposefully do it. But I just haven't had good results with it. And I think that maybe it's because really to get that full anesthetic result that you want, you have to reapproach to get the musculocutaneous nerve. For those of you that don't know, your axillary block it's not an axillary nerve. It's the brachial plexus at the axillary artery. And you're trying to get the radial, ulnar, and median nerves that are around the artery. And you don't necessarily see those. And that's another reason why I'm not a huge fan of the block. It's like, just get the needle to the area and it should all work out. You're not actually trying to necessarily hit those nerves, which I don't know. I like a little bit more of a black and white kind of hard and fast. No, actually go to the nerve and block it. So I think that vagueness of the axillary block is what bothers me. And then, as I said before, to try to get full results from it, then you have to reapproach and go get the musculocutaneous nerve. And so I just haven't had as much luck with it. I think patients also are a little weirded out by getting injected in the armpit. That's like an uncomfortable place to stick a needle. And even on my literature review of it, it hasn't really seemed to be super effective, at least like in the pediatric population. I would use this block in a both bone forearm fracture. That would be why I would want to use this block. But again, I just haven't really seen the results. I don't know. I don't know if any of the other guys here have had better luck with it. It could be me.
I have to confess, I've never actually done an axillary block. I've done an interscalene and I've come down to the forearm, but I've never gone in between. About you guys?
Yeah, that's how, above and below is where I was taught. But theoretically, I guess there's some interesting things that will be helpful in terms of the complications of interscaling. But yeah, it seems technically difficult and shaky hands at this point.
Yeah.
Speaking of interscaling, Zach, you mentioned that interscaling is one of your favorite blocks.
Yes, as Ashley mentioned at the beginning of the program, I think it's really good for shoulder reductions. And I actually use it for both shoulder reductions and humeral head fractures. I like with the interscaling block that I can avoid a procedural sedation. So especially if you're working in a place that is more remote, that has lower nursing staffing, and you can get something done without having to have a nurse in the room, someone else performing the procedural sedation, and someone performing the actual reduction of the shoulder itself. What I like to do for this is I like to do the interscaling block, leave the room to give it some time to allow the patient for the block to take and allow the patient to relax a little bit. And then I see another patient if there's another couple of patients that are waiting to be seen. And then I come back, I do the reduction and put the patient in a sling and either confirm the reduction on ultrasound or send them for a post-reduction x-ray. I actually love this block for that reason of I can just do it without having to worry about other things. And I've actually had patients that come in and have had shoulder dislocations before. And I say, hey, let's try something new. Let's try a nerve block. And every single one of them have loved it. And they've all said, hey, this was so much better than when they knocked me out last time, because I just pop it back in and I'm able to get them home a little quicker. I don't have to wait a lot for that post-sedation time. I do use lidocaine if I'm doing a shoulder reduction as opposed to BUPIP, just because I want that shorter duration. And then you need to make sure that you do a good neuro exam before, because I've definitely had someone with decreased hand grip from the block itself, just the fact of the matter of me blocking the brachial plexus.
Now that makes sense. I like the interscaling block. It definitely has, I think, more complications than some of our other blocks. So I don't know that I would go to it as your first block. Let's put it that way. But it is a very useful block. I know I work in an environment where sometimes we're very far from surgical capabilities, and the interscaling is a great block for arm amputations if you have to transfer them by plane to avoid excessive opiates en route. All right. Now, Zach, you also sent me that the transgluteal sciatic block isn't a great block for you. I got to be honest, I've never heard of this. Are you like lying people on their stomach and blocking through the gluteus to the sciatic nerve? Because no, that does not sound comfortable to me.
So basically what you're doing is you're actually lying them on their side typically.
Okay, that's better, I guess.
You are blocking through the gluteus muscle. You're using the curvilinear probe, so similar to a peng block, it's a deeper block. But as opposed to a peng block, which is more of the plain block, and you have the backstop of the pelvis that you can hit, you're actually looking to get down to the nerve with the needle, and much like a median nerve block, surround it with lidocaine. There's a couple of issues that I've run into with this. First of all, patients are very resistant when they come in for sciatica, just looking for medications that they've had in the past. I've had patients say, no, I don't want you to stick a needle in me. I just use these Tylenol and lidocaine patches. So certainly I only use it for patients where they are difficult to control pain-wise. And then another thing is it depends on body habitus, how deep you have to go. And I've found that in some patients, the angle that you have to take with the needle makes it very difficult to actually visualize it. And then finally, like one of the things that I really don't like about it is that one of the side effects that can happen, it doesn't happen all the time, and I've only really had it happen once or twice on me, is that they get a foot drop. So, all of a sudden, this person who came in just because of sciatic pain, I blocked them, their pain's gone. But now they have foot drop, and now I have to tell them, hey, I'm going to put you on crutches, and this will go away when the block wears off. Now, there was a case series that came out a few years back that said just injecting saline alone worked for some patients. And I thought that was really interesting because that decreases the need for lidocaine, so it decreases or eliminates your risk of LAST. And it also is just, the idea is maybe it just decompresses the nerve in general and decompresses the muscle compressing on the nerve. And so my understanding is that there's a couple of sites doing randomized control trials comparing lidocaine versus just injecting saline into this area. So that will be something that I'm looking forward to hearing in the future. But currently, with the foot drop and with how difficult it is to actually visualize the needle, it can be a harder block. But I do like to use it as opposed to trying opiates in patients with sciatic nerve pain, which I think opiates are really just not a good option for those patients.
Can I ask a question, Zach, about that?
Yes.
And this is, I don't want to derail everything, but it's something I think about all the time. And how often, thinking about this gluteal block or just thinking about any block, do you say, I'm going to try this block? You start to do your pre-scan and you ultrasound things and you're just like, okay, this anatomy, I am not going to block this patient. Wave off, whether it's because it's too deep or because there's so much, calcification in the superficial structures, or fill in the blank. How often do you find you guys like trying to do a block and then deciding, nope, not worth it?
So from what I've done in my practice is I don't typically offer the block until I've ultrasounded. I usually just say something to the extent of, hey, I'm going to look on ultrasound, see if I can see the sciatic nerve. And then when I look there, I assess, first of all, if I can see the nerve at all, because sometimes it's just too deep and the body habitus makes it so that I don't think I'll be able to reach it. And then secondly, I try to figure out, is this something that I can actually, that the patient may tolerate based on the amount of pain that they're in? And so I usually pre-scan before I even start talking about nerve blocks in patients. And that avoids me having a 10-minute discussion trying to convince them to do a nerve block and then coming back with the ultrasound and finding that there's no good anatomy. I do the same thing for my shoulder blocks. I pre-scan for anatomy. So I usually put the ultrasound probe looking at the shoulder to prove a dislocation. And then I say, oh, I'm just going to switch to the linear probe and just check to see if I can see the nerves. And then I look at the nerves. And if I feel like the anatomy is good, then I start to say, hey, look, these are your nerves. I can do a nerve block on you. Was that something you'd be amenable to? It, for me, has decreased the amount of patients that I've chatted with about a nerve block to consent them and then have to go back on that and say, actually, you're not the best anatomy for this.
Actually, do you feel like actually showing them their nerves increases their interest in the procedure?
I found yes, especially with the interscalene. I'm like, see this stoplight looking thing? I'm just going to come down under ultrasound guidance and I'm just going to basically block this. And that's going to mean that you're not going to be able to feel the reduction at all. And the size of the needle that I'm using is no different than the size of the needle that you got for your IV that we've already placed.
I like it. You're kind of like playing your cards close to your vest until you're sure how this is going to go down. All right. So before this episode, Andrew, I asked y'all to talk about integrating nerve blocks into the ED, because this is definitely not something everybody's doing right now, but it might be something that people are interested in doing. And Andrew, you sent me this like whole proposal written out. So you've clearly had some experience on this, on the pillars of system change. And that was provider training, cross-specialty buy-in, system-wide protocols, nursing education support, and robust QA. I loved that. Tell us a little bit more about those steps.
I'm a nerd for pedagogy, but so essentially, yeah, I've worked in a couple different institutions, left each time of my own accord. But I used to be a fellowship director, just get that out there. But I come to a place where we started several residencies at once. So it was like a big GME push and introducing a new technique, fill in the blank, ultrasound-guided IVs, ultrasound-guided nerve blocks, or anything. The best way to fail at something is to mess it up the first few times. And so you need to prepare yourself for success in the same way you prepare a sterile field and get your ultrasound positioned in the right way. And you have your sort of radius of influence and this is where I'm going to make a change. You have to do that with the system as well. And so the idea there is we concentrate on, we want to make sure our individual providers are trained up enough to do that. And that is that is going to these courses, that is listening to these podcasts and so on, that is doing different sims. But then there's also the idea of I'm going to nerve block somebody. And it was brought up that some of the impetus for doing the hip blocks came from orthopedics. I was in that same situation where essentially nursing leadership came to me and said, hey, orthopedics wants to think about instituting a hip block protocol for the ED. And I said, fantastic. Here's all the papers I know about it. Here's how it worked the last time, where I was. Let's get together and have some meetings. So you need other people to be interested in that, not least of all, because as was mentioned with the nerve exam, if you are seeing someone and blocking them before the subspecialist necessarily has a chance to see them, they need to have confidence in your nerve exam. You need to make sure that your providers are documenting a good nerve exam. So everyone needs to be on the same page. Sometimes say we're doing our discharge instructions. If you're kicking someone out, make sure someone's there to catch them. But so you need the other specialists to agree what's a good block, what's a block that everyone agrees is at high risk for compartment syndrome. And so therefore maybe not a good candidate, and go through from top to bottom, including nurses. Because again, that nursing protocol situation, making sure that they know what to expect, making sure that they know how to address patients' concerns when the numbness and tingling starts to come back, making sure that there's overlap with the pain medication as the expected nerve block wears off. They're going to want to have pain medicine on board. So just making sure everyone's ready for that, supporting nurses and our other colleagues in that regard. And then finally, making sure that like any program, you have the ability to go back and see if your program is working. So making sure you have good QI type protocol and that you're tracking that and seeing where things are not working out. So it's a big task to move the Titanic, but it's I think worth it at the end.
Definitely. I remember a few years back, I was at a facility that was starting to do nerve blocks in the ED. I wish I'd had your outline because I did all of these steps, but not in the right order. And a lot of them after I'd accidentally upset someone. But yeah, like you talked about the cross-specialty integration. I remember it occurred to me that I should talk to pharmacy far later than I should have. But eventually I was like, I should talk to a pharmacist about this. And in the course of that conversation, it turned out that our interlipid was stored really far away from the emergency department. And to get it, you had to place an order, and they said they could send a courier, but it would take 10 to 15 minutes. And so then we had to pause for a second and go through this whole request to get this one bag of interlipid that lived, it's probably still there, in our emergency department, specifically for regional anesthesia before we could go live with it. And we wouldn't have thought of that without talking to the pharmacists. So.
For sure. And
yeah, I think involving, sorry, go ahead, Andrew.
No, I was just going to tag on pharmacy is important. What percentage of bupivacaine versus ropivacaine versus lidocaine, which one is kept in the place where we've always kept it in our suture cart, which one is kept in a Pyxis. All of that needs to be worked out. Sorry, Ashley.
No, I was just going to say, when we started our program, one of the first things that we did was, first of all, we talked with anesthesia so that we our procedure to theirs. So we'll use the same exact anesthetic and the same anesthetic amount when we do our fascia iliac block or when we do our Pang block. We even use the same needles. We even said, what needles do you guys use? And we use the same ones. We just don't use the little electrode thing. But then we immediately involved pharmacy because we created an order set. And when we first started doing this with the large volume blocks, we would actually have pharmacy at bedside with an intralipid kit. And then once they saw that we're not causing last all the time, they were like, yeah, you can just, it's okay. We're in the department. We don't have to actually be in the room. But making sure that there's an intralipid kit ready, available in the ER, I think is absolutely paramount to any place that's going to start doing large volume blocks. And that that interdisciplinary buy-in is huge as well. And if for anybody that wants to start this, I would start with anesthesia, because I think that saying to them, hey, you don't have to get consulted to come down to the ER to do these procedures, because they never want to come to the ER, and then just trying to mirror your procedure to theirs, I think will get you far.
I do really want to know where y'all are working that your consultants are this on board.
Yeah.
We had a different experience. I spent
Mm.
a lot of time getting buy-in specifically from the orthopedic surgery service. Anesthesia was very on board for exactly the reasons that Ashley just pointed out. They didn't want to come to the ED. They got more than enough of blocks on their own. But the orthopedic surgeons definitely took a couple meetings with a huge literature review and discussion of what this was going to look like and all sorts of fun things.
Yeah, it was interesting. Our ortho docs just didn't really seem to have any issue with it at all. I was definitely prepared to have huge discussions with them, and they just were okay. Like, they just didn't bother them. I don't know why. Our trauma surgeons love it. Our trauma surgeons actually they admit our hip fractures now. And so every hip fracture that gets admitted, the trauma surgeons are like, hey, can you get a resident to go do a block on that? So that helps too.
Great.
And I think if it's not a recommendation, and certainly literature in the trauma orthopedic literature that sort of recommends blocks. And the fact that it's their own literature is obviously a big point.
So in the last kind of couple minutes here, I wanted to transition into returning to an earlier topic, which was if you were interested in incorporating nerve blocks into your practice, but didn't learn it in residency, as most of us didn't. I didn't learn this honestly until after fellowship. What techniques do you have to offer folks? What kind of resources do you have? I know, Zach, you mentioned meat models, which I thought sounded like a really great option, and I was hoping you could expand on that a little bit.
Yeah, so the way that we have done it at Yale for both the faculty and the residents is using meat model workshops. So for faculty, we have a faculty development series. So once a month, it's a couple hours, and faculty can show up and we can work on a skill that they don't have much experience in, or it's a lecture on something to help improve your practice. And so we took one and we did a meat model course. So it cost us less than $100 in supplies and approximately 2 hours to make the models the day before. And these models are great because you can actually inject into them. And so we put on this basically lecture and then hands-on experience for the faculty, because our thought was if the faculty aren't comfortable supervising the procedure, then we don't only want nerve blocks to happen when there are ultrasound trained faculty on. And then we had the residents do it during their conference. And so it was really a good opportunity for them to get experience we did fascia iliaca, we did just a regular like median nerve block, and then we did an interscalene block. Along with serratus. Serratus is pretty easy. There's some great articles available. I think there's one out of Maimonides talks about how to actually make the meat models. And so I think that's a good opportunity to just practice on something better than the phantoms out there currently don't allow you to inject into it. So just as much as you can track with your in-plane approach, you can't actually get that experience hydrodissecting. You can't actually get that experience feeling a pop through the actual fascial plane, which you can get using the meat models.
Yeah, plus the models that you can buy are crazy expensive for what they are. Just absolutely insane. Just felt like I needed to add that. Thank you, Zach. Yes, I've had some similar luck using chuck roast. I like chuck roast because there's a lot of marbling to it, so you can have a lot of different fascial planes to play with.
Yeah, but I have found that if you take like chuck roast or pork loin and wrap it around a hot dog, I don't know why, but the hot dog really shows up like a nerve on ultrasound.
I like it. I'll have to try that one in the future. I've been using
try it out.
like kebab sticks. Kebab sticks really look like nerves, and they're easy to stick through the meat. All right. Yeah, it works really well. And if you are, for example, teaching at a conference, you can buy all of it at the local grocery store the night. All right. What online resources would you guys recommend if someone was interested in learning more about the topic?
Sure. I can say that the two that I have on my phone are Safe Local, and that was put out by, I believe, an anesthesiologist from Johns Hopkins. And it essentially is just a quick add in the comorbidities, do a little bit of a calculation, and make sure that you're well within the amount of a safe amount of lidocaine. Almost all of these blocks are obviously not going to get to that high concentration danger zone because, again, even the fascial plane blocks, it's mostly the volume, so you dilute down your lidocaine anyway. But it's always just nice to have that just quickly available. And then the one that I like just because it's free is the Nerve Block app. And I use that one. It's literally the icon is a little block. And I just like to remind myself before I go into the room what like the map is, what the distribution, what I'm expecting. And it's just a nice refresher to have for the just-in-time learning. And then a shout out to a YouTube channel that I really like is Regional Anesthesia and Acute Pain Medicine. And I believe, again, those are anesthesiologists out of Duke. I just like their teaching. It's free on YouTube, and the way they go through things works for me. So those are the three that I'm a big fan of. And then I'll just add on, obviously, we have prior Unmute Your Probe lectures on regional anesthesia. So you can absolutely go back into our catalog and find those as well.
Yeah, we do. I was going to plug that at the end if no one brought it up. They are great. And if you're an AAEM member, you can still get CME for those. Ashley, Zach, do you guys have anything you'd like to add?
I will say it's not a free app, but I do use the Nysora app. I find that it's pretty user-friendly. I like how it's broken down.
I also like the 5-minute sono from Core Ultrasound. They've covered a
Mhm.
bunch of different blocks, and especially just being able to sit there with your resident and going over in a quick video of it that just really hits on the highlights of the block.
I'm gonna add one more. I really like the ANSO app. It's ANSO, the Anesthetic Society. It has cartoons with all the anatomy, and then it has a sonograph of the anatomy. I really like it for teaching because I think it helps people to see the cartoon and then to see it. I think there's a paid version. I have the free, and it's always had everything I needed in it. All right. So before we go, I'm going to ask you guys one last question. And this one I did not look at your answers in advance, and I'm really interested in hearing what you guys have to say. So we've had this whole conversation about nerve blocks, and more than once what has come up is the training needed to do this safely and do this effectively. So with that caveat, would you say that this is a procedure that any emergency physician could do, or should it be reserved for those with fellowship or more advanced training?
I have thoughts. I think a lot of procedures, it depends on if you've done the training. If you're out there, like if you can't do a fast exam, I don't care if what you're doing is a fascia iliaca block from that point of view. In the same way that an interventional cardiologist, interventional radiologist, or a vascular surgeon who's had the training can open up like a femoral artery with a sheath, like those kinds of things can be done by whatever, as long as that additional training has been undertaken. We do procedures all the time, from lumbar puncture to central access. We've gotten to the point, I think, now where ultrasound-guided vascular access is relatively commonplace. And once you get that skill of ultrasound plane, target, and needle and their relationship and how they work, as long as you're aware of the risks, benefits, complications of the procedure, the motto is, if you don't know, have a go. I think that sort of anyone could do this if they've had the training in that specific procedure or skill.
I agree with
Yeah,
Andrew.
absolutely. You go ahead.
I agree with Andrew. I've supervised both residents and even supervised a few medical students that are fourth years who have a lot of ultrasound experience in a procedure such as the fascia iliaca block, because as you mentioned before, there should be no vasculature, kind of around the area that they're going for. And I'm right there behind them holding the anesthetic. So there's no injection unless I actually see the needle itself. I do think that you probably need to do about 5 to 10 nerve blocks total to get that in-plane skill. And whether that's trying on a meat model, but I really do think you need some experience supervised by an ultrasound faculty member. I think that this is something that should be taught to everyone in residency, because I think that every resident should leave with at least 5 to 10 nerve blocks so that they can go out and they can practice in the future where they can do this. Because honestly, like Andrew said, we do a lot of pretty risky procedures in the emergency department relative to the risk of a nerve block. And everyone leaves having done hundreds of ultrasound-guided IVs. This is just doing it in the in-plane approach in most settings instead of the out-of-plane. So I think that this is something that every resident graduating emergency medicine residency should know how to do and should feel comfortable with.
I agree. I don't think that you need to be fellowship trained. I don't think that you need to have specialty training. I think that nerve block shouldn't be your first thing in ultrasound that you learn how to do. I think that there's 3 different things you need to understand. First of all, you need to be able to recognize the anatomy on ultrasound. You need to know what you're looking at. So you need to start doing all of the ultrasounds to get a feel for that. What's a nerve? What's a tendon? What's a vessel? And then you need to have that hand-eye coordination of being able to follow your needle in plane. So that's like kind of the second step. And then the third step is the knowledge around it, right? Knowing which anesthetic to use, which block to use, what are the risks? Should I be blocking grandma with COPD? Should I really be doing an interscaling block on her? Probably not. And then I think having those resources to reference is super important, like knowing which resources you're going to go to. Because even though I do nerve blocks all the time, I'm often still looking at that resource to double check the volume, the distribution, all of those things. Like you shouldn't just expect that you're going to memorize all of those things. So having that resource that you trust is important. But I think this is something that all residents should be learning in emergency medicine residency.
Definitely. I would say intubating somebody is probably a riskier procedure than a medium forearm block if I was gonna weigh those two things. All right. Thank you all so much for coming on today's episode. And thank you, Dr. Ashley Grant, Dr. Zach Boivin, and Dr. Andrew Shannon. If you are interested in learning more about this, as Dr. Shannon pointed out, the AAEM website, the emergency ultrasound section, we do have prior episodes of Unmute Your Probe, including a couple on specifically regional anesthesia. Come back next month and join us for an episode on the use of point-of-care ultrasound by military physicians, particularly in deployed environments. Thank you.
We hope you have enjoyed this podcast from the American Academy of Emergency Medicine. AAEM is a nonprofit professional association of over 8,000 emergency physicians dedicated to board certification and democratic group practice. For more information about AAEM, visit our website at www.aaem.org.